partiality, but I'll try to be as impartial as possible, and I'll give this sheet to the All India Ophthalmic Society. So the first speaker is Dr. Vavikar. He's going to talk on comparison of clinical parameters in two different IOP settings in active century in cataract surgery. Dr. Vavikar, please. No, I can't hear you. I can't hear you.
Hello.
Now I can hear you.
Good morning, everybody. I am going to talk on comparison of clinical parameters in two different IOP settings on active Centurion machine. It was funded by Alcon. All the ethical and legal considerations were met with. The aim of the study was to evaluate the benefits of active Sentry in low, that is 20, versus high, that is 50 millimeters of intraocular pressure during phacoemulsification. The primary endpoint was comparison of CCT, central corneal thickness on post-op day 1, whereas exploratory endpoints were endothelial cell density, active surge mitigation, BCV है, आगे नहीं जा रहे हैं. Mean CDE, US time, patient comfort, and antechamber flare and sales. Materials, it was a prospective, comparative, double-arm, randomized, single-blinded, interventional, single-center, single-surgeon study involving 112 eyes, two groups of 56 each. The control group was 50 IOP and the interventional group was 20 IOP. Inclusion criteria, standard, well-dilating pupil, grade 3 cataract, and no other complication, where any post-op complication or intra-op complication, the cases were taken out. Results, you can see that demographically both the groups are very well matched. Phacoemulsification parameter, again USG and CDE is both equal. There is no statistically significant difference. Central corneal thickness, of course there was an increase in the thickness up to 3.5%, but the difference between the two groups was not statistically significant. Endothelial cell density, again there was on an average loss of 3.5% of the cells in both the groups, but there was no statistically significant difference between the two groups. Active surge mitigation, over here we found a lot of difference. In 20 IOP group, it was initiated only in 12% of the cases, where as compared to 43 in 50 IOP group, which is statistically significant. Even the number of instances were much higher in 50 group as compared to 20 group, which is again statistically quite significant. Pain comfort, no difference between the two groups, CDVA, no difference. So in a nutshell, there was no difference in any parameters except ASM, that is active surge mitigation, which was much lower in 20 group as compared to 50. Now we have been doing cataract surgery with a high bottle height, to reduce surge and complications like PCR and corneal endothelial damage. But that also has its own flip side, that is subtle ocular ischemia, inflammation, difficult surgical maneuvers during deep AC, etc. Prior to development of Centurion vision system with active Sentry technology, there was no suitable technology available for risk-free low IOP cataract surgery. In Centurion, we have active Sentry, that is a quick wall technology. That means there is a shortcut for reflex mechanism, and therefore we have what is called as ASM, that is active surge mitigation. Even if there is a microflutter, ASM kicks in and that is avoided. Now there are three factors which affect this. Number one is surgical techniques, but it was a single surgeon study. Eye anatomy, patient, on the groups were matched, and so the only difference between the two was the machine setting, that is the IOP setting. And therefore we can safely say that low IOP is significantly safer as compared to high IOP, because of as far as ASM instance, that is microflutter is concerned. And microflutter obviously will mean that of course the major flutter also won't be there. So what we feel that when we lower the IOP, we are worried that we'll get surge. Here the situation is different. You can safely do surgery with 20 IOP. Now it is not possible to use 20 IOP in all the patients, but you can say most of the patients. So conclusion, it is equally safe to perform cataract surgery with near physiological or 20 millimeters IOP in comparison to 50 in Centurion Vision System with active centric technology. As far as the anterior segment surgery is concerned, we did not go into the posterior segment, as far as the complications or problems are concerned. 20 IOP cataract surgery using active centric causes much less AC fluctuations, which is the major cause of concern for any surgeon who is doing cataract surgery, and therefore it provides much safer milieu for cataract surgery. Thank you.
Thank you. Do you have? We don't have a discussion in this, no? In prepare. You can ask questions. Dr. Vavikar, even if there is, if the anterior chamber is shallow, or if there is thrust, or the patient squeezes, will you keep the same IOP of 20? I've also got an active sentry, and I feel it's safer to remain at 30 or 40 in these cases, especially when you have problems, because you don't want to, just to lower, just for the sake of lowering the IOP, you get into trouble with a PC rent, because even little higher IOP, we have not seen optic nerve damage and other things which the company talks about.
Yes, sir.
So I feel that the safety of the patient is paramount. Whatever IOP you have to safely keep for that particular surgery.
Yes, sir. Very valid point. Actually, this is what the study concentrate on, that even at 20 IOP, there is no surge and flutter. At the same time, as I said, that it is not possible in every patient. Say out of every 20 patient, one patient comes when there is so much of fluctuation that you better shift to 30 or 40 IOP. What we have seen is endothelial loss and CDVA, corneal thickness, everything is unaffected when you use 20 IOP. Another point is that there is a lot of learning curve. See, from 30 to 20, to reach from 30 to 20, I took as many as 6 months. And I had to manipulate the aspiration flow rate, vacuum. Luckily in Centurion, we can have 3 settings for vacuum, 3 settings for aspiration flow rate. That is pre-occlusion, occlusion and post-occlusion. And all these things were manipulated, and that is how I came to these settings.
Did you include very hard cataracts, 4+, 5+?
No. This study was only for grade 3 cataracts and below cataracts.
And you were able to complete all the cases with 20 IOP?
Yeah. Yes. As I said that, ma'am, out of 20 patients, there comes one patient where, 20 IOP is not good enough, and we have to increase the bottle height to 30 or 40 IOP. But majority of the cases, if we set the parameters properly, it is possible to do the case without any risk or endothelial damage or, PC rent.
I think we will go to the next speaker, because this is an endless sort of topic.
Yeah, thank you, sir.
Thank you. Thank you, Doctor.
The next speaker is Dr. Tamil Rasi, and his presentation is hydro-free mechanical delamination, a novel surgical technique. Is he there? Sorry, I can't pronounce his name properly. Dr. Tamil Rasi. Your name? Huh?
Dr. Srisha Kumar. Yes. Dr. Srisha Kumar.
No, this is not.
Co-author is Tamil Arasi.
But that is no other name.
Yes. Srisha Kumar.
Okay. Sorry. Dr. Srisha Kumar.
Good morning. My presentation is on hydro-free mechanical delamination, which is a novel technique in PPC, a retrospective analysis in 60 eyes. We all know posterior polar cataract is a rare form of congenital cataract, and the incidency is somewhere around 3 to 5 per 1,000 cases. And there is a chance of posterior capsular rupture or nucleus drop because of the...
Please set the timer properly.
Because of the
Please start the timer.
Please start the timer from 0.
Yeah.
5. Okay, now please.
So because of the abnormal adhesion of the posterior polar opacity to the posterior capsule, there is a chance of PCR or subsequent nucleus drop. So the incidency of PCR ranges from 4% to 36%. In the older studies, it used to be very high, but because of the improvement in the surgical technique, better understanding of the cataract and experience of the surgeons, the incidence of PCR has significantly decreased. And the last paper which was presented on this showed a PCR rate of 4%. The purpose of the study is to analyze the outcome of hydro-free mechanical delamination in a case of posterior polar cataract. Here, this is an animation and a clay model showing the procedure. We use a Sinskey hook or even a bent cystitome to create a 360-degree partial thickness groove between the endonucleus and the epinucleus. It's totally hydro-free procedure, and once that is done, the endonucleus is emulsified, and the similar procedure is repeated. The delineation is done between the epinucleus and the cortex, and the epinucleus is then emulsified or phacoaspirated, and then we do a cortical cleanup and place the lens. So throughout the antechamber is maintained, and the contour of the cornea and the globe was maintained throughout, and we use phaco was done using slow motion technique and with the reduced parameters. So all the patients underwent thorough preoperative evaluation. Thorough slit lamp evaluation was done to assess the status of the posterior capsule, and anterior segment OCT was done only in 41 of 60 cases, and in one case we could see a PC defect, and this is a case. The surgery was done under peribulbar anesthesia here, but most of the cases we even did it under topical. And Sinskey hook is used to create a delineation between the endonucleus and the epinucleus, and the separation of the corticocapsular adhesion was also done using the same instrument, and then the endonucleus was emulsified under the cover of epinuclear cushion, and the epinucleus was then emulsified, and throughout the chamber was maintained, and then a 360-degree cortical cleanup was done. So the hydro was avoided just to prevent any inadvertent escape of fluid into the subcapsular space. So we included 60 cases of 54 patients, of which 48 underwent unilateral surgery and 6 bilateral, and the follow-up period ranged from 6 to 25 months with an average of 12 months. And of the 60 cases, 57 were soft cataracts, and only 3 had a moderate degree hard cataract, and mechanical delamination was possible in all the cases, and we could place the lens in the bag. So only one patient had a pre-existent PC rupture was there in the beginning, and this is the same case wherein we did the same procedure. After the emulsification of the endonucleus, since it was a very soft cataract, we could do a irrigation aspiration to clean the cortex and place the lens. So the procedure of phacoemulsification in a case of PPC is challenging, and the approach to a case of PPC requires modification in the surgical technique. Our technique of hydro-free mechanical delamination is easier to master and with encouraging results. Thank you very much.
This is the first time I have heard of a totally hydro-free. How do you achieve it? I don't know. How do you achieve hydro-free? Hydro-free, because a wave of fluid has to go to be able to separate the endonucleus from the epinucleus. And how do you achieve it? Won't you, if you try to rotate it, won't you damage the zonules? Because if you put extra pressure on the zonules.
Yeah, we have selected cases which were soft cataract. Almost all the cases except 3 cases were soft cataracts, and we usually by doing a delineation mechanically will be damaging the zonules, but this was a very soft cataract. Easily we could delineate using a sharp instrument. The horizontal chopper I have used in most of the cases, and a long Sinski hook in some cases have used. And even the endonucleus from the epinucleus and the epinucleus from the cortex was delineated before aspirating or emulsifying it. So we could do it easily in all these cases. It works very well. There may be some accidental escape of fluid into the subcapsular space while doing phacoemulsification, but intentionally it was not done.
All the cases in AIOS2025 had no pre-existing defect. Was it like that?
We could do it in 41 cases out of 60 cases. In the 41 cases, only one had a PC, defective PC.
What was confirmed on an anti-sanguine OCT? Or?
Yes, sir.
Yeah. Was that case also in the
that is the case. The second case which I have shown, where I have implanted a multifocal toric lens, it was implanted in the bag. There was a small defect which was not enlarged during the surgery. It was maintained.
Okay, doctor. Thank you, doctor.
Thank you. Thank you.
The next presenter is Dr. Abhijit Kumar Handik, a new technique of needle-assisted intrascleral haptic fixation in scleral fixated IOL. Over to you, doctor.
Good morning, everyone. Through this presentation, I'm going to introduce a new technique of needle-assisted intrascleral haptic fixation in SFIOL. I have no financial interest to disclose. Secondary IOL implantation in absence of capsular support has gone through an eventful journey. In 1986, it was Melbourne. We used sutures to fix the IOL in the retropupillary space. The revolution came when the Gabor in 2010 introduced the haptic externalization technique. It was further simplified by Yamane in 2014 and created another revolution. In 2017 and 2018, Bhaskaran and Khatri tried to modify the technique further. But the question always remains, why only a handful of surgeons do SFIOL? In our perception, it may be because of demand of special surgical expertise and dexterity. The most procedures don't yield consistent result. And some of the complications like IOL-TIL issues and consequences faced by many surgeons. In our new technique, we tried to achieve the surgical consistency to make the procedure easy to adopt by most of the surgeons and to achieve TIL-free stable IOL fixation. Let's see the technique through this video. Continuous infusion is a must in the closed chamber technique. This is a subluxated IOL, and we had to explain this. And the particular in this technique is that creating a curved needle using a 26.5 gauge needle using a wire contourer or a needle holder. The first haptic is out using a straight needle. This special needle is used to create a needle track to which the haptic is fed. When the needle is withdrawn, the haptic will be fixed in the scleral tunnel. Then now this haptic is firmly secured, which has no chance to go back when we will be externalizing the other haptic. We can see the use of this special curved needle once again. The curved needle is used to create a needle track. To the bore of the needle, the haptic is fed, needle is withdrawn, and the haptic will be again fixed into the needle track. The beauty of this technique is that we have chance to readjust the IOL, the fine tuning, which is not possible in techniques like tip melting technique. So we can compare the needle track fixation. Even Yamane and Gabor has also, not Yamane, actually Gabor and Khatri, they use a needle track technique. Gabor, he uses a forceps, Khatri uses a straight needle. But in our technique, we used a curved needle, because of which it can negate the orbital rim and we can choose any meridian for IOL orientation. The pilot study in 22 eyes, by the time we submitted this presentation, we faced mostly the cases with cataract surgery complications. In post-op, we faced high intraocular pressure and some intravitreal hemorrhage, which could be manageable. But the beauty is that there was no IOL decentration and demonstrable IOL tilt. The perceived advantages are the firm fixations could be achieved. We could avoid the empty needle track difficulty. And accidental full thickness scalp perforation is almost nil because of the rudder effect of the needle design. Predictable needle tip emergence negates the orbital rim, so we can choose any meridian if we wish to. Easy haptic fading in the needle bore because needle bore is away from the sclera, and fixation is one haptic prior to another. The slippage is almost nil, and no demonstrable IOL till in the pilot study. So in the conclusion, curved 26.5 gauge needle assisted needle track implantation technique appeared to be easy to adopt, had good consistency and no demonstrable IOL till in any of the cases till now. There's a YouTube link for more videos in this technique. Thank you.
You've been doing this technique for quite some time, and I think anybody else has not used that curve. How easy is it to maneuver this curved needle?
It's like the curved needle we use in ECC cases. It's quite easy.
It is easy to use this curved needle intraocularly. Also, it's easy to use it.
Yeah, it's because it's mounted on a syringe, and we can use it easily.
To engage the haptic.
Yeah. And to engage the haptic, I have used a micro forceps, but any other forceps can be used, even a McPherson.
What was the purpose of this? What do you want? Did you want to make it simpler for a starting surgeon, a beginning surgeon, or is it more complicated for a surgeon who's starting? Does it require a more experienced surgeon? From what I get, you have done this so that even a more inexperienced surgeon can do this.
Sir,
is that true? Because from your procedure, it didn't look as if it's so easy for a beginner surgeon to do this.
Sir, if I tell about me, I have started with the sutures. I have done even the Yamane's technique, but I was fixed with the Gabor's technique because of stability. But in the Gabor's technique also, I faced difficulty in most of the cases. But when I improvise it in this way, believe me, I have not faced any issues. And lately, I have done some cases in PK cases also, ECC cases also, where the eye is quite soft.
Okay. Thank you.
Thank you.
Thank you, sir.
I call upon the next presenter, Dr. Apurva Mansod. Capsular convexity and capsulorhexis challenges in intumescent cataract. Post NDR glazer as AIOS2025. Over to you, doctor.
Good morning, everyone. I'm Dr. Apurva. I'll be presenting our work on intumescent cataract. With the pioneering future, we are pioneering the future with next-gen technology, but still operating on an intumescent cataract poses a challenge for all of us. In spite of multiple difficulties, the real challenge lies in making a good capsulorhexis. There are multiple studies which prove that NDR anterior capsulotomy is highly effective and safe. Now, when we did it in our center, in some cases we found excellent results where there was significant flattening of the anterior lens surface. While other cases, like this case of Morganian cataract, we didn't find much difference. Now this led to a research question, ki what are the anterior segment parameters which will affect the outcome of the NDR laser, and what are the intraoperative challenges in these cases. It was a prospective interventional study. We included 90 patients who were diagnosed as intumescent cataract on slit lamp. We excluded patients for whom we were not able to take a good scan, posted for femtosecond, any complicated surgeries, or if there was a capsular fibrosis noted. We did preoperative biometry scans for all of them. Now, on AIOS2025, the patients were classified into 4 groups based on the AIOS2025 classification given by Dr. Titya et al. Group. So here, if you see, this is the type 1, where there are regularly arranged lamellar cortical fibers with very minimal clefts. This is type 2, where the clefts have increased and there are continuous hyperreflective bands of hydrated cortical fibers. Going to type 3, these clefts join together and forms a homogeneous ground glass appearance along with intralenticular clefts. Finally is the type 4, where it's a uniform homogeneous appearance of the anterior lens cortex. Now, after classifying these patients, all of them underwent an NDR laser capsulotomy almost half an hour before the surgery, and we targeted areas of fluid. And post-laser, the AIOS2025 scan was repeated. Now, on AIOS2025, we looked at the following parameters. One is the crystalline lens rise, that is the distance between your the line joining the angle recess and the anterior lens surface, the anterior chamber depth, and the front radius of curvature of the anterior lens. So these are our results. This is a patient showing pre and post YAG. So if you look at the anterior curvature, it has flattened significantly. Now this difference was clinically, statistically significant, especially for group 2 and 3. Similarly, if you look at the circumferential lens rise, pre and post YAG, it has decreased from 1263 to 613, and the difference was significant again in grade 2 and 3. Similarly, the anterior chamber depth increased. Now, when we did a multiple regression analysis, we found 3 factors which were clinically which were significant. One is the lens thickness. So when you compare, a 1 mm increase in lens thickness caused a CLR change, that is the effect of YAG, increased by 26 micron. The cataract class, as we saw, type 2 and type 3 gives you the best results. And third is the pre-CLR, that is the lens rise. A 100 micron increase of CLR caused an effect of 13.7 micron. In coming to intraoperative challenges, we reported no cases of Argentinian flag sign, posterior capsular rupture or nucleus drop, and in all patients the lens was implanted in the back. This comes to our conclusion that preoperative OCT helps us in classifying and planning a cataract surgery. NDR laser capsulotomy is highly safe and effective. We reported no complications. And the 3 factors which affect the outcome is the lens thickness, the grade of cataract, and the circumferential lens rise. Thank you.
Doctor,
sorry, please.
What is the time gap you give between doing the laser and taking out for surgery?
So we keep at least 30 minutes, max 30 minutes, because if you go beyond that, that causes edema, and that can affect you, because
Correct.
the fluid comes out, and if there is a lot of egress of fluid, that can affect your visibility.
IOP also can go
Yes,
up.
sir, yeah.
So 30 minutes is the upper
30 minutes is the max, but we try to shift the patient as fast
early
as possible.
Tell me, what did this has been done earlier also. What was the originality in your study? So,
sir, here we try to find out, we don't need to YAG all intimate patients. So for us, AIOS2025 scans are generally uploaded on this. We see the scan, we see as I said, the 3 factors which affected. The lens, we look at the lens thickness on ILMaster or Argos. We look at the grade of cataract. If it's a grade 1 or a grade 4, I will not send my patient for the YAG. Third is your circumferential lens rise. So as I showed the graph, here you can say if my CLR is almost 1000, I know how much effect I can expect.
So how do you choose your patient in which you do a YAG, or you only do a needle capsulotomy, or do maybe a femto capsulotomy?
So if it's a femto,
so do you make a choice between the 3?
So if the patient has opted for femto, on catalyst the incisions are so fast that you won't need a YAG capsulotomy. And also if you have done a YAG caps, the fluid comes out and then the femto will not help because that will obstruct the energy. Second thing is we look at the AIOS2025 scans. Depending on, we have not compared other methods with anterior capsulotomy. What we found is these patients do better. It's a preference choice, but like saying in favor of capsulotomy, it's a closed chamber. Second thing is, if you look at INTMAT, there are two spaces. There is the anterior and the posterior compartments. So if you're doing a spiral capsulorhexis or any on table, you are decompressing only the anterior compartment. So in anterior capsulotomy, you do decompress the anterior, but by the time the patient is shifted to OT, the equatorial barrier between the lens anterior capsule relaxes. That breaks the barrier between the cap, and that way the posterior compartment also decompresses.
What is the percentage of cases you do in this, and what would you do it only? What is the percentage of cases in which you do anterior capsulotomy this way? Generally.
For few surgeons, they based on few surgeons prefer YAG capsulotomy. So based on AIOS2025 scan, we post them for we send them before surgery. Others have different techniques. So
in
that's
your
surgical
study,
preference.
how many you had to take up for YAG capsulotomy, and how many you had to
so
just
we
decide
diagnose them on INTMAT. We diagnose them on slit lamp. If we are seeing fluid clefts and if they have been diagnosed as INTMAT, we took all of them for YAG so that we know which patients do better. Now, if you see type 1 didn't do better, good, or there was not much significant change.
So in your study, all cases you did?
All INTMAT cases we posted for YAG.
Okay, thank you.
Thank you.
The next paper is by Dr. Shehal Jeena.
Shehal Jeena.
Shehal Jeena. Is she here?
Shehal Jeena? No, I think she's not there.
Go to the next. Is Dr. Prabhajot Singh here? His topic is metallic intraocular bodies following torsional phacoemulsification.
Good morning. I am presenting a paper on metallic intraocular foreign bodies following torsional phacoemulsification surgery.
Is this timer set correctly? It's already 3
So
minutes.
phacoemulsification is the preferred technique for cataract extraction, but there is a documented risk of release of metallic particles. So we set out to conduct an observational study analyzing routine cases of cataracts undergoing phacoemulsification surgery. Our primary objective was to determine the incidence of these foreign bodies and related visual outcomes following phacoemulsification. So we observed 300 eyes undergoing routine phacoemulsification with an infinity vision torsional phacoemulsification using a 0.945 degree mini flared ABS tip, using a stop and chop technique with a two-handed usual approach, having a Sinski or chopper in left hand. And the phaco tip was either changed or sterilized after 10 cases. And we identified the intraocular foreign body either intra-op or during post-op on slit lamp. In our results, we found that the cumulative dissipated energy was significantly higher in the foreign body group, that was 12.9, and it was significantly lower in the foreign body absent group. These are the foreign bodies we found. The small silvery shiny foreign bodies were found in the main port or the corneal side tunnels, which we found in 6 patients, and these are the foreign body found on the iris surface. You can see the foreign body near the pupillary margin in 4 to 5 o'clock hours. Then we followed these patients for 6 months, and we found that in 2 patients the foreign body disappeared. Then we did gonioscopy, and we could only localize foreign body in one of the patients. In another patient, that foreign body disappeared. We could not appreciate any foreign body in posterior chamber or posterior segment. Then we analyzed the phaco tip under 40x slit lamp magnification, as this foreign body did not cause any high risk, so we did not go for scanning electron microscopy. On 40x biomicroscopic examination, we found there were small grazing linear abrasions on the phaco tip, which corresponded to the size of foreign bodies we observed in our cases. The characteristics of the patients with metallic foreign body, there were 6 patients out of 300 patients. Most of the patients had a LOCS nuclear opalescence grade of 3 to 5. That means all the patients had a higher cataract grade in which the foreign body is developed. Even the BCB was pre-op BCB was significantly higher, lower in foreign body group. There was significant positive association with higher cataract density and presence of intraocular foreign body and a positive correlation coefficient, and the similar degree of correlation was found between CDE and risk of retained intraocular foreign bodies. To conclude, the retained intraocular foreign body was found in 2% surgeries. As I already said, higher cataract density CDE was associated with increased risk of foreign bodies, which suggests there was a direct relation between the energy utilization and foreign body formation. The major contributor was direct contact between the vibrating phaco-tip and the second instruments. The other contributor was brief unintended interactions between the instruments, inherent flaws in phaco-tip design, or either we used higher phaco energy settings or there were denser cataracts. To mitigate such risk, we should employ careful power modulation based on cataract density, a single-handed phacoemulsification technique wherever and whenever possible, a rigorous instrument inspection protocol, and a regular microscopic inspection of these phaco-tips. This is the first systemic documentation of the relationship between retained intraocular foreign body density and cumulative dissipated energy parameters. Thank you.
Firstly, tell me how many times do you use a phaco needle?
We use it for 10 cases on an average.
And did you find it more after about the 9th to 10th case, or did you find it even in the first case that you did this metallic foreign body, or was it not related to that or related to the harder cataract?
It was not related to the number of the patient, sequence of the patient, sir. It was only related to the density of the cataract.
And normally you change your tip after every 10 cases?
Around 10 cases. In this study, normally we do not, but in this study, for 300 cases, we did that to avoid any bias or confounding factors.
And did you use the original tips from Alcon?
Yes, yes.
Did you get any foreign body in the first use, first or second maybe?
No, we did not.
It's usually in the latest.
So only in the nuclear opalescence grade 4 or 5 we found the foreign body.
Even with the new tip?
Hard cataract is there.
Yes.
And when you get first time phaco,
First use.
first case with the needle, and then 10th case with the needle.
So we did not keep a record of the sequence of the patients as such. We only analyzed the.
That would have been a
That
good
is a
parameter to follow
shortfall in the
also.
study, that you did not keep.
That was the major flaw.
Yeah, that was this thing that you didn't keep it, whether it was in the first case or in the 10th case. And was it related to the hard cataract in the first case or the 10th case?
Understood.
Hardness being the same, did it appear in the first case also?
Maybe
Hard
you
cataract
should
first
try
case
that, doctor.
Or hard case,
Since only few cataracts were hard, so I don't think it was related to the.
And also the metallic body didn't produce any problems in the
No, no patients had any trouble. No EC reaction, no vitritis, nothing, sir. No long-term sequelae after 6 months follow-up.
Because the Alcon recommends for single use. So if you tell them anything, then they will say that did you get it in the first case? Then they can have some manufacturing things to answer for. But if you because these are all written single use, and we never use them for once. We've used them multiple times.
That's not possible
By in Indian circumstances, that's not possible.
Have these cases been followed up? I mean, when metallic part is there, you removed it?
No, we did not remove it, sir. It was not causing any trouble. We followed up for 6 months. There was no complications, so we did not do anything.
You mentioned that the foreign body was.
Do you know what is sidrosis?
Sidrosis, yes.
What is that?
So that is due to the metal release from the foreign bodies causing the ocular sidrosis. But in our patients, there was no posterior segment foreign bodies, and there was no complication after 6 months. Even in documented literature.
But the foreign body you saw, you had removed it?
No, we did not.
That is lying there in the eye.
That was very small metallic silvery particles.
Ions are even smaller.
I think the material
I think
also,
the
I don't know what the
sidrosis-
material
now
is
next
made
paper
of.
should be
I think
sidrosis,
we can go on
incidence
to
of
the next
sidrosis
case
after
because
this.
I think all of us have small metallic bodies, we see them.
And they
lie,
harmlessly
they
lie there,
lie
they don't
inert
do
in the
any harm.
anterior chamber.
Yes.
So, and we have not, I think, trying to fish for them and trying to take them out might
Because it will be more damaging removing
cause
them.
more damage than to let them remain there.
Actually, if you just go and apply aspiration with eye cannula, it comes out very easily. So
Sometimes they are
if
entangled, sir. They don't
if
come
they are in
out.
the crypts of the iris, then it's very difficult and to
Doesn't
fish
come
it
out.
from the crypts is not worth
Then
it.
you will be damaging the
I've been
iris.
using this for I've grown old using this.
Fine,
So I don't find anything, no cirrhosis in these cases.
Correct.
yeah, only
I have using
it's
a
a-
Alcon machine for this same thing because it's an
2
Alcon
decades,
machine you have to use because that's the only machine which has this torsional phaco. So I've been using it for the last 15-20 years. So next
if,
page.
yeah, if it's a new tip, if you do phaco in the plastic chamber, which is provided for calibration, okay, if you do little bit of phaco, many times the foreign body goes into that and you won't get it in the eye.
We'll go on to
we'll
the
have to go
next
on.
case because
Sorry, we'll I think have to go on to the next.
the next presenter is
Thank
Dr. Nandita
Yeah.
Manjunath. And she will be presenting on Rain the Haptics, innovative approaches to overcome IOL implantation setbacks in cataract surgery.
This is done. Next.
Next one.
Yes,
ये
yes.
तो हो
This is
गया
not
अभी।
my presentation.
The next one.
Yes.
Next page presentation.
Good morning. My name is Dr. Nandita Manjunath, and the title of my presentation is Rain the Haptics, where we talk about the innovative approaches to overcome IOL implantation setbacks in cataract surgery. Phacoemulsification is one of the modern cataract surgeries, and we use foldable implantable IOLs like trifocal, multifocal, and toric and monofocal IOLs, to name a few. Now, these surgeries may be met with certain setbacks, for example, the IOL implantation setbacks. These can be broadly classified as optic or haptic damage before, during, or after implantation of the IOL, and it may sometimes lead to compromised visual acuity due to a different IOL power being implanted, or the patient may be left aphakic. Further diversifying the causes, the optic or haptic damage before implantation can be due to bent or missing haptics, or broken or optic or a haptic, and sometimes due to sterility issues. During implantation, it can be due to a bent, broken, or stuck optic or haptic. And after implantation of the IOL, it can be due to an inadequate capsular support due to zonular dialysis or posterior capsule rupture. We aim to identify the complexities leading to IOL implantation setbacks and determine its contributing factors, and also to recognize the surgical technique for IOL explantation if used, and to compare the IOL implantation setbacks before and after implementation of certain preventive strategies. This was a retrospective study done in a duration of 1.5 years. We included the phacoemulsification surgery cases that underwent IOL-related complications or setbacks, and we excluded all the uneventful phaco surgeries. 29,630 phaco surgeries were analyzed using the surgery notes and the lens reporting form for the various reasons of the IOL implantation setbacks. This is the example of the lens reporting form that we use at our hospital. From this, we can know the exact step and the exact cause for the IOL implantation setback and the technique of explantation. We collected data regarding cause for the IOL implantation setback, the type of the IOL, details of IOL replacement if any, method of IOL explantation, and the final visual outcome on post-operative day 30. Of the 29,630 phaco surgeries, 155 cases had IOL implantation setbacks, which roughly amounts to 0.52%. The avoidable setbacks were optico-haptic damage before or during IOL implantation, and unavoidable setbacks were due to sterility issues and complications. About 82.4% of the IOL that underwent setbacks were monofocal foldable, whereas 9.2% were EDOF lenses, 4.6 were advanced monofocal, and 3.9 were multifocal lenses. 17% of the cases used toric IOL power. Majority were hydrophobic lenses and 27% were hydrophilic lenses. Of the cases that underwent setbacks, majority around 40% were identified before implantation of the IOL, 28% were during implantation, 17% were sterility due to sterility issues, 9% were due to complications, and 6% were after implantation of the IOL. 71% were preloaded lenses, whereas 29% were manually injected. Of the cases that underwent IOL implantation setbacks, 90% needed an IOL replacement, of which 60% were implanted with the same power lens, and 10% of the cases did not require an IOL replacement. In 15% cases, a 3-piece lens was placed in the sulcus. Of the cases that needed IOL explantation, in 26 cases the section was extended, whereas in 20 cases the section was extended and the IOL was cut and removed. In 15 cases, only the IOL was cut and there was no section extension. Sorry. On assessing visual acuity on POD 30, we found that 80% of the cases had visual acuity between 6.6 to 6.9, and 15% had visual acuity from 6.12 to 6.60. We implemented certain preventive strategies like placing visual cues in the operating theater to enhance guidance during the IOL implantation, regular training of the staff of both the paramedics and the surgeon for proper IOL loading techniques. Injecting the IOL under a IOL magnifier improved the precision significantly. Pre-warming of certain lenses increased the optimal lens flexibility. We implemented these in the month of March 2024, and we analyzed data from January 2023 to June 2024. And we found that the average, before implementation, the average phaco per day was 76, average implantation setback per day was 0.94, and after implementation, even though the average phaco of day was increased to 93, the average implantation setback was reduced significantly to 0.42. In conclusion, I would like to state that proper documentation of these setbacks is of utmost importance. Implementation of preventive strategies reduce the rate. Regular training of staff is important, and for the surgeon to always inspect under the microscope before implantations. Thank you.
One or two questions. What were the sterility issues? I mean, how did you know that it was not sterile? All lenses that we pick up are sterile. How did you classify them into sterility?
So,
how could you even think of putting an unsterile lens?
So sometimes the lens slipped, and it was of course not used, but the lens slipped during implantation.
So that you didn't implant, no?
No, sir, we didn't.
If it fell on the drape?
Yes, sir.
When it fell out.
Or
Yes,
fell out in a sterile area, or even an unsterile area. Supposing it fell on a sterile drape, you consider it sterile or unsterile?
So we considered it as unsterile.
Okay. Other thing is, how did you pre-warm a lens? I've noticed that the haptics get stuck when you keep the lens in the operation theater, which is very cold. And how did you pre-warm these lenses?
So we used a pre-warmer.
What is a pre-warmer? We just keep it over the autoclave or something like that.
So we
and
use
on
a
the
warmer.
surface of the autoclave for some times, because it becomes a little warmer in our winters, and especially if the air conditioning is very, very effective. So how did you pre-warm these lenses?
So we use this IOL warmer where the lens can be placed
There
here.
is something called an IOL warmer.
Yes. So this is the IOL warmer where we place the lens here, sir. So it's pre-warmed before the surgery.
And what is the difference between preloaded lenses and the lenses that you implanted, which had to be put into to the case?
So certain lenses are already preloaded before.
No, I know that, but was there a difference between the breakage of the preloaded lenses versus breakage of the
Preloaded lenses showed higher complications, she said.
Yeah, I didn't. But that is usually not so, because
preloaded lenses are always trouble, sir. We also don't.
I don't think so.
Invariably, while trying to inject, we need to reload, or we need
preloaded can't be reloaded. Which lenses are we? I mean, we use preloaded lenses mostly from Hoya, which are with one of the best injectors.
Hoya we have not used,
best
sir,
injectors in the
preloaded lenses coming with the other companies not so good.
Clarion nowadays, which with the preloaded, is also very good.
Have you experience with Indian preloaded lenses?
Indian preloaded, exactly.
They
are not so effective.
Because preloaded lenses are something that we look forward to now. And they go, especially.
That is why we tried in the Indian companies, and they are not so good.
Indian companies?
Yes, sir.
Yes.
I never wanted to say, but
You have to say that.
It's about the discussion. Yeah, see, 70% of the loaded lenses they had problem. Only 29% of the lenses to be loaded had problem, which is a reverse to our experience.
Manually.
But that
Very
is
true.
Manually injected loading is 71%.
Yeah.
No, manually injected 23%.
23, 71 to 71%.
That is preloaded. Blue is preloaded. We also face
Sir,
the
it's a
same
surgeon preference. Some lens, it depends on the surgeon. Some surgeons do it by themselves, and some it's loaded by the surgical assistant.
Very good.
loaded by the assistant, they were more prone to these problems.
So we didn't find significant.
No, I'm sure in her study all were loaded by the staff. Correct? All the cases were loaded by the staff in your study?
Some were also loaded by the surgeons
Surgeons
themselves.
also.
Yes,
But you didn't differentiate that.
Yes, ma'am, we didn't differentiate.
But anyway, it's a very good paper.
Thank you, sir. Thank you, sir.
So we'll go on to the next presentation by Professor Arvind Kumar Maurya. Clinical trial, sewing needle microcapsulotomy versus small needle aspiration to avert Argentinian flag sign.
Live, please. Yeah. So good morning, esteemed judges and my dear friends. So my talk is on a clinical trial between the sewing needle microcapsulotomy versus the small needle aspiration to avert the Argentinian flag sign. And I have no financial interest. So as we see that the Argentinian flag sign is a self-propagating radial extension of the anterior capsular tear, and which typically arises instantly after an initial prick with a sharp hypodermic needle or a sharp tip rexis forceps. So the Perron gave this term the most common complication of the intumescent cataract, and how it is happening. So it is a sequelae of the raised intralenticular pressure, but there are other factors also that are leading the propagation of the initial prick into a radial capsular tear. So there are many factors responsible, like the high pressure anterior compartment, propelling posterior compartment, and a forward thrust of the nucleus is also responsible. And there are many techniques to overcome. So there are two-stage capsular rexis, mini rexis, phaco-capsulotomy, precision pulse capsulotomy, puncho-rexis, Brazilian technique, and the flax also. Then this technique of a small needle aspiration, it involves pricking the anterior capsule with a sharp 26 gauge hypodermic needle, followed by simultaneous aspiration of the liquefied lens matter to decompress the bag. But often the peripheral extension of the capsular tear, it happens instantly after pricking the anterior capsule, even before the liquid cortex aspiration is initiated. So it means there had to be some other factors responsible which assist the raised intralentricular pressure to propagate the splitting of anterior capsular tear resulting into the Argentinian flag sign. So this was the this technique published in JCRS. So what is not known that it is the configuration of the initial puncture created to open up the anterior capsule by the sharp tip hypodermic needle or the rhexis forceps. What does lead to? This puncturing the anterior capsule with an ultra sharp beveled hypodermic needle or the sharp tip rhexis forceps. So there is always a small linear cut with open edges along the entry as seen in this video. So what is not known, it is a raised intralentricular pressure that triggers the disruptive force along the discontinuous open edge. So we can see that the tear always extends radially along the discontinuous open edges of the linear cut, but it is never perpendicular to the tear. So we came with a hypothesis that if we are able to manually create an opening in the anterior capsule which had a round and regular configuration instead of a linear cut, we may provide resistance against the disruptive forces and thus the Argentinian flag sign can be prevented. So we made this very simple novel instrument known as sieving needle microcapsulotomy with a smooth rounded point tip similar to sieving needle. As you can see, now the opening is round and regular. So this is how it is done, very simple technique, round hole microcapsulotomy with round regular configuration. So thus the liquefied lens matter egresses as soon as we make a round regular opening, and the rhexis, then it becomes very easier. And you can see the very round regular opening, a small opening is there in the after zooming in, and then the rest of the this steps of the capsular rhexis, ideal rhexis of 5.25 to 5.75 as a piece of cake. So these were the result, the 53 cases of the small needle aspiration, 7 extended into the Argentinian flag sign, whereas in sieving needle, 1 extended, so with a significant p-value difference of 0.001. So in conclusion, in intumescent white cataract, it is primarily the linear cut configuration that is responsible to spontaneously extend along its open edges leading to Argentinian flag sign, whereas the sieving needle microcapsulotomy with round regular configuration like a capsulotomy in true sense provides resistance against the disruptive forces triggered by the high intralentricular pressure. So the initial decompression of the capsular bag, it facilitates safe and controlled creation of a capsular rhexis of a desired size with higher level of efficiency and safety. Thank you so very much.
Is this the original design? Have you patented this, or
yes,
is
it's patented.
And it's available. Is it your own this thing, because or somebody else has been?
It's our team, Dr. Rajendra Prasad sir, Dr. Anurag Badhani.
Okay, the same thing.
So we are the same team. The paper got published in JCRS, so with the same team.
Okay, that's okay. I was wondering, Dr. Rajendra Prasad.
Yeah. So I'm part of that team. Yes,
okay.
Even that paper I can show you. It's my name is there.
Then it's
yeah. Yes, sir. Here my name is also there.
All the cases that you tried with this needle didn't have the flag sign.
Now we have done 50, in this study only 53, but we are doing it since regular basis. So more than 200 cases, so all are doing well. Even now the residents are doing it and they are very much comfortable.
And also the tip, how is it? Very sharp? The tip is very sharp?
Very sharp.
Tip is, but it is round?
Yeah. Entry is very sharp. But then 0.3 millimeter round and regular is there.
Who makes this in the commercially available?
Yes, it is commercially. Epsilon.
Epsilon
with Epsilon. We don't have any financial interest in it.
I know, don't. Yeah. But if can we get this just to try it out?
Yes.
Actually, the concept is very great.
Yeah.
Instead of making a linear cut, while starting itself, you try to make a V or round. It works.
So whenever we are doing that linear cut, so it is extending radially.
Exactly.
This is what happening because there are two irregular edges.
Correct.
So that is leading to this Argentinian flag sign. But when we are using it, sharp pointed tip, so it gives a very nice, and we can do multiple in the central
punctures also.
Yes, multiple punctures also based on the AIOS2025-Free. So we can do multiple also.
Thank you, doctor.
Thank you so very much.
We'll go on to the next presentation by Dr. Shriya Hinge, 4 flanges for second sight. outcomes of a novel technique for scleral fixation of IOL in aphakia. Dr. Shreya Henge is available? Not available. Dr. Mishra Gaurav? Not available. Dr. Rajendra Prasad? Not available. Dr. Hebinth Bryan? Dr. Hebinth Bryan available. Okay. New generation pupil expansion device, iNova. Over to you, doctor. They'll come late or they may not come?
Will they come at 10:30? We can close the session if they don't.
Yeah. Good morning to all. There's a whole array of pupil expansion devices. They are flexible structures, device. They are employed to maintain the pupil in a dilated position throughout the length of the surgery. So in that we have the well-known things of VX rings, which gives a 5.5 mm pupil expansion in a hexagonal shape, which engages in 5 points. And we have the Malugin ring, which we have a injector. We need an injector for it, and it can be injected through a 2 mm incision, and it gives almost a nearly round pupil of 6 mm. And the modified version of Malugin ring is the Gupta ring, which has 4 scrolls, like 2 above the iris and 2 below the iris, and it's not a preloaded version, and it engages the pupil at 4 points, and it gives a dilatation in square shape. The latest addition to this collection is the iNova pupil expansion, and it is developed by Aurolab. It gives an overall diameter of 8.3 mm, and it's made of silicon material, and it gives a uniform radial expansion. It's 360 degree. It will be attached with the iris, and it can be positioned with 4 positioning holes to engage and to remove. It gives an inner dilatation of almost 6.3 mm, and it comes with a preloader injector of which can be injected through a 2.8 mm. So this is how the device looks, and it comes with a disposable injector. The cartridge, this is a cartridge, and it fits with the 2.8 mm incision comfortably, but with wound assisted it can be injected to a 2.2 mm also. And here you can see the device which is inside the cartridge. So the OVD has to be injected in the cartridge before injecting the device. And first, while you try to engage the iris, there will be 2 grooves in this device. I'll be showing this. So there's the upper groove and the lower groove, and the iris pupillary margin has to be engaged with between these 2 grooves. So first try to distal edges engaged in the groove of the device. We can use a Sinskey hook to engage the pupillary margin. It looks too bulky, but it's near. The reality is actually it is thin and flexible, and you can see this is the margin. So the important thing in this device is like it can be the 360 degree of the iris is engaged, and while engaging the last part of the ring, gently retract the iris to engage the pupillary margin in the groove. And it gives enough ample space also. So this is how the inner diameter will be 6.3 mm. So after implanting the IOL and before removing the visco, you can disengage with the same Sinskey hook. So there will be a minimal spincher tear, but it will give a post-operative, it will give a nearly round pupil, and you can remove it by using a McPherson's forceps or even with another Sinskey hook also. So the pupil shape is not much altered. So to summarize, this biocompatible silicon material based device is INOVA, which helps for smoother insertion and delivery. Its circular configuration results uniformly round pupil dilatation. It provides a 360-degree contact with the iris and achieving 6.3 mm dilatation. This device provides an excellent working space, at the same time prevent inadvertent iris damage. Compared to all device, it is very economical also. The recommendation is, in case of rigid pupil, especially in less than 3.5 mm, the stretch pupilloplasty should be done in any pupil before attempting any pupil expansion devices. Thank you.
I noticed that there is a lot of pigment dispersal, and because after you engage the lens into the groove, and when you removed it, there was quite a lot of, and also the edges were crenated after you. In a malignant ring, at least which I have used, you get a perfectly circular pupil, which with no dispersion of the iris. I mean, it costs much more, but I have been using it.
No, sir.
The other thing is that was when you implanted it and when you are doing was it if in a floppy iris syndrome, did this ring try to come out? Because some of the rings just come out from the flanges when in a floppy iris.
No, sir. It was like there were some difficulties in few of the cases, but in majority of the cases, it didn't happen anything, any trauma to the iris.
Okay. Thank you very much.
Can you reuse this?
No.
No,
ma'am, it cannot be No. It's disposable.
No, officially disposable, but can you ETO it and use it? Because we use our malignant rings quite often.
Malugen ring we can use till it breaks.
And I've got the trick of how to keep it in.
Sterile it become little, the flexibility will be reduced. That's it.
I mean, I don't know. I hope people not recording this would.
Okay.
Thank you.
Thank you. The next presenter is Dr. Jatinder Singh Bala. Is available? Okay. Are you Dr. Jatinder Singh? Yes, Indian designed to prevent Argentinian sign in intumescent cataract.
Yeah.
Over to you, sir.
Good morning. My topic is prevention of Argentinian flat sign by an Indian design in cases of intumescent white cataract. Slide is not moving. Slide is not moving.
Slide is not moving.
You see, there is no standard definition for intumescent cataract given in the literature, but Centurion made it an objective assessment by any cataract thicker than 5.5 millimeter with flocculent white cortex and anterior chamber depth less than 2.2 millimeter. The general pathology in intumescent cataract is high intralenticular pressure, loss of structural integrity, and there is thinning of the lens capsule which tends to extend equatorially. So we did a study where we did AIOS-OCT guided management of intumescent white cataract, because we found that in some of the cases of intumescent cataract, you get Argentinian flat sign, but in some of the cases, you don't land up with this dreaded complication. So our primary objective was to evaluate the incidence of incomplete rhexis in AIOS-OCT guided management. And so this was done in Department of Ophthalmology at Deen Dayal Upadhyay Hospital in New Delhi. It was carried on 50 patients for 1 year period from January 2023 onwards. And these were the inclusion and exclusion criteria. The method of measurement of outcome of interest was based on AIOS-OCT. We found whether there was presence or absence of fluid pocket, subcapsular fluid pocket or intralenticular fluid pocket, and what is the location of these, whether it was peripheral, central, or both central and peripheral, which we labeled as diffuse, and what is depth and size of this fluid pocket, because we found this helped us in better management of our intumescent cataract cases. So group 1 was 25 patients which was having absence of fluid pockets, routine CCC was performed, and group 2 patients were having peripheral subcapsular fluid pockets, where we did 2-stage central capsular access, because we found when there is peripheral subcapsular fluid pocket, you can still without any risk touch the center, but only thing is you have to do 2-stage central capsular access. But patients having predominantly central fluid pocket, this is tense bulging fluid which is making the capsule very tense in the central part. So we did not touch the center of the capsular bag here, and we went through the periphery, and this we labeled as a peripheral capsular access. So these are some of the OCT picture. The first one is predominantly central fluid pocket, second is predominantly peripheral fluid pocket, third is both central and peripheral, and fourth is intralenticular fluid pocket, and there is no subcapsular fluid pocket. So based on this, we made an algorithm with subcapsular fluid, and if it is central, go peripheral, and if it is peripheral, go central, and without subcapsular fluid pocket, then you can do routine central capsular access without any fear or danger of having Argentinian flag sign. So this is 2-stage capsular access, where you initially made 3 mm central capsular access, aspirate the fluid pocket and decompress the capsular bag, and then give a nick in the equator of this circumference of this small capsular access, and extend it to the desired size of 5 to 5.5 mm capsular access. And where we did peripheral capsular access, in the central fluid pocket, or both where central and peripheral is there. So what we did here was, we bent needle, 26 number needle at the junction of outer 1/3 and central 2/3, go through the side port, and again make a nick in the peripheral of the capsular bag. That is again junction of the peripheral 1/3 and central 2/3, while going with the bevel down. While going inside, aspirate the fluid pocket, and then after filling with visco, give a radial cut with micro scissor. After this, 2 peripheral cuts are made, and then 2 peripheral flaps are raised. I'll just have a small video on this.
Time is up.
The video is not running here. It was running there. No. Free. Mind you, with bevel downwards, you go inside from the periphery, aspirate the fluid pocket so that you decompress it. Now you make a linear cut with a micro scissor, and then 2 perpendicular cuts. So you have 2 peripheral flaps which are raised. Rotate one circumferentially, and then you rotate the second circumferentially, and these 2 are joined. And what you get is a round circular opening without any danger, because the reason was, because of the central fluid pocket, you have not gone through the center, you have gone from the periphery. So what are the observation and results? We had central subcapsular fluid pocket in majority of these patients, that is about 16 patients, and peripheral fluid pocket was there in 6 of these cases. And the complete access was obtained in 25 of these, that is about 100%, and where fluid pocket was present, about 96%, that is 24 of 25 patients, we were able to make a complete access. So there was hardly any complication, and you were achieve almost 96% success success. In one patient where we were not able to, where we had equatorial extension was because we did not go from the junction of the peripheral 1/3 and central 2/3. We were too peripheral, and maybe because of the zonules there was traction and it went equatorially. So in our patients without fluid pocket, capsular access was complete in all the patients. And in patients with fluid pocket, where we did peripheral capsular access, we were able to achieve success in 96% of these patients. So we use preoperative AIOS-OCT as a guide to decision making our capsular access technique based on objective assessment of presence or absence of fluid pockets. AIOS-OCT can identify true intumescent white cataracts with imminent risk of capsular access extension. It could help formulate a management plan based on the presence or absence of fluid pockets on AIOS-OCT. In our study, we observed that 25 patients having fluid pocket, capsular access was extension was noted only in one case, and where there were no fluid pocket, no peripheral extension was noted. So future recommendation is that employing just one technique for all types of intumescent cataract will not yield you safe 100% results. Presence or absence of fluid pocket and the size of fluid pocket can help us to decide about the technique of rhexis that you should adopt in various types of intumescent cataract. And AIOS-OCT can really be an objective tool to assess which cases, which technique should be applied. So take home message is, knowing what you were going to encounter on the table beforehand pre-operatively helps you to be better prepared to handle such cases rather than discovering it on the table during surgery and then deciding what to do about it. Because forewarned is forearmed, and employing one technique for all types of intumescent cataract will not yield the desirable outcomes because one key may not open all the locks. Thank you everyone for your kind and patient hearing.
Dr. Bhalla, everybody doesn't have an anterior segment OCT. Yes. So this is, you are assessing it on the basis of an anterior segment OCT, with the fluid pockets on the basis of that. So I think your few people will be lucky to have anterior segment OCT before tackling an intumescent cataract. So I think many might have to resort to other methods.
So my humble take on that is, these days OCT is available with most of the practitioners, so you can make assessment. But even if you don't have anterior segment OCT, what you can do is adopt peripheral rhexis in all your intumescent cataract, because majority of your intumescent cataract will have central subcapsular fluid pocket. So irrespective of whether you have AIOS-OCT or not, adopt this technique and you will be happy to know that you will not have peripheral extension and Argentinian flax. And this is what I have been doing.
Take home message is that the bevel should be down.
Bevel should be down.
And it should be in between the 2/3 and 1/3 of this thing, 2/3, 1/3 in inner, and it should be eccentric.
At the junction of the peripheral 1/3
and a central 2/3. And it should be this thing. You should make a puncture there.
Puncture there, and then aspirate, and then make with a micro rhexis forceps, make a radial incision right up to the center. Now you will have two flaps. Go through the side port, rotate one flap and to almost 180 degree, and from the second side port pick up the second flap and again rotate it circumferentially. Join the two, you will have a complete round circular opening.
Okay, thank you so much. Thank you.
Right.
The next presenter is Dr. Srishti Kullar. Dr. Srishti is available? Okay.
No, that is the last.
There are 4 people who have not come. I will read out again if they are not available, and then we will finish the session. Dr. Rajendra Prasad, Dr. Mishra Gaurav, Dr. Shriya Hinge, Dr. Shihail Jinnah,
What is it?
Then
Ophthalmic Society West Bengal.
Clinical Microbiological Profile of Post-Cataract.
Is there something called
Ophthalmological Society of West Bengal, Clinical Microbiological Profile of Post-Cataract Surgery and Ophthalmitis. You have that? Okay.
Is that a paper?
And is it a paper? Okay.
State paper. Okay.
Presenter is Pragati Paul. Okay.
मैंने कहा एक और presentation नहीं it is done. मैंने कहा एक और यहाँ तो फिर लिस्ट में तो नाम नहीं है.
A report from Eastern India. Role of polymerase chain reaction in the management of post-cataract endophthalmitis.
Good morning, everyone. My topic for today's paper is the clinical microbiological profile of post-cataract surgery endophthalmitis and the role of polymerase chain reaction in the management, which is a report from Eastern India. Endophthalmitis is defined as the inflammation of the inner coats of the eye resulting from intraocular colonization of infectious agents with exudation within the intraocular fluids. So early intervention with a targeted antimicrobial therapy is crucial for the effective management. The diagnostic techniques of staining and culture remain the gold standard, although the culture positivity rates vary widely, and therefore PCR can rapidly detect the microorganism and aid in selecting the appropriate antibiotic as well as the antifungal agent. The primary aim of the study is to provide a clinical and a microbiological profile of the post-cataract surgery endophthalmitis from Eastern India, and the secondary aim is to elucidate the utility of PCR and its clinical implications in the management of the same. It's a retrospective case series ranging in a time period of 2015 to 2023. The staining, culture, and PCR methods were adopted. Intervention was based upon the clinical diagnosis and PCR positivity. Intravitreal antibiotics were administered. Vitreous surgery was done as and where indicated. The favorable anatomical outcome was defined as a clear media and attached retina. Favorable functional outcome was defined as a best corrected visual acuity of 20/200 or more. This is a tabulation of the demographic details, and we can see a total number of 132 eyes were taken for the study. The microbiology results have revealed that in a culture-positive patient of 51, the PCR positivity stood out to be 100%, and in a culture-negative patient of 81, PCR positivity stood out to be 70.4%, and this value was statistically significant. Amongst the 51 patients of positive culture, 21 eyes had a favorable anatomical outcome, and 18 eyes had a favorable functional outcome. Amongst the 81 patients with negative culture, 60 eyes had a favorable anatomical outcome, and 58 eyes had a favorable functional outcome. And the difference between the culture positivity and culture negativity patients was statistically significant as well. Amongst the 81 patients with negative culture, there were two groups. Group A were the patients who were positive for PCR, and 51 eyes had a favorable anatomical outcome, and 50 eyes who had favorable functional outcome. And Group B were the patients who were negative for PCR, and those were 10 eyes where there were favorable anatomical outcome, and 9 eyes who had favorable functional outcome. So the whole cohort results have depicted that the favorable anatomical outcome was achieved by 81 eyes, and the favorable functional outcome was achieved by 76 eyes. So the most common gram-negative organism which was isolated from our study was Pseudomonas, and the most sensitive antibacterial agent now it is ciprofloxacin. And the most common gram-positive organism which was isolated from our study was Staphylococcus epidermidis, and the most sensitive antibacterial agent was vancomycin. So the commonest gram-positive isolate was Staphylococcus epidermidis, and the commonest gram-negative isolate was Pseudomonas. The gram-positivity sensitivity was highest for vancomycin, and the gram-negative sensitivity was highest for ciprofloxacin. So our study yielded a culture positivity rate which was lower than the studies by Gupta et al. From North India and Lalita et al. From South India, but it was similar to the study by Sharma et al. From Eastern India. And the present study has found Pseudomonas species as the commonest isolate amongst the post-cataract surgery endophthalmitis. So our study shows ciprofloxacin has replaced ceftazidime being the most sensitive antibacterial agent for a gram-negative microorganism. And the role of PCR comes into the play because it helps in timely intervention, since it is the cornerstone in the management of endophthalmitis. And PCR also renders the results earlier, thereby allowing the clinicians to intervene, and aids clinicians in instituting the treatment based upon the results of eubacterial and panfungal genome. So in our series, patients with culture negative yielded better outcomes vis-a-vis the culture positive patients, which implies that PCR helps in early diagnosis and targeted therapy. So it is the time for paradigm shift in endophthalmitis intravitreous, and therefore we should consider vancomycin, ciprofloxacin, dexamethasone empirical therapy, which substitutes the standard dictum of vancomycin, ceftazidime, and dexamethasone. PCR also allows early intervention, which is imperative to perform in all cases. So the limitations of our study is that it's a single center study having a retrospective analysis, and a large nationwide antibiotic registry is important. So to conclude, it is the largest study from Eastern India providing the latest microbiological trends. Pseudomonas species, which is the commonest isolate amongst the post-cataract surgery and endophthalmitis from our study. Ciprofloxacin is more sensitive for the gram-negative isolates, whereas vancomycin is more sensitive for gram-positive isolates. Polymerase chain reaction, it is the standard of care in the management of a post-cataract surgery and endophthalmitis. These are my references. Thank you. Thank you, sir. Thank you, ma'am.
What is the dose of ciprofloxacin and intravitreal and?
Yeah, so the one which we took was the standard one, 2.25 milligram per 0.1 ml. Thank you, sir.
And then follow with the Cipro itself.
Ma'am, pardon?
Drops. Do you follow up with ciprofloxacin drops?
Yes, ma'am. We gave ma'am Moxi. Later on, when we were taking the patient for a follow-up, either we started with the OPD VCD regime again, or we gave the topical moxifloxacin or tobramycin, like as a follow-up for 1 month or so.
Is it
The intravitreal is what you are mentioning as Cipro.
Yeah, like ma'am, as follow-up, we did it later on for 1 to 2 months, but we used to follow up the patient every week, and then we started with the OPD settings. Instead of giving a VCD, like a vancomycin, ceftazidime, dexamethasone, we would give a vancomycin ciprofloxacin, dexamethasone in the OT itself.
How is it different from the general management? What do people do generally? How is this more original than the others?
So the first thing that we actually saw is that the ceftazidime, which is usually preferred in an OPD setting, like vancomycin, ceftazidime, dexamethasone, instead of empirically giving that, we started with the vancomycin ciprofloxacin. The reason behind it might be the ceftazidime resistance which has come into play. And also there was a study by Jindal et al. It showed a temporal variation in the etiology. So maybe the organisms which are coming to play in the post-cataract surgery and endophthalmitis are changing over a period of time. So empirically, we need to be ensured that we are coming in terms of what is the common organism at this point of time, because 20 years before, whatever was the common organism might not come to play right now as well.
Okay, thank you. Thank you very much.
Thank you.
Just one point. If you feel that now ciprofloxacin is the one which is showing the organisms are showing least resistance, then why post-operative period you are using moxifloxacin and tobramycin? Why not continue with ciprofloxacin also? Why replace it with moxi?
Yes, sir. Absolutely, sir. Thank you, sir. So the basic thing is we obviously need a nationwide antibiotic registry. What we have is just from Eastern India. So what right now, like for instance, in our center in Shankar Netralaya, we are giving ciprofloxacin, but initially we were giving moxifloxacin and tobramycin. But for the last 5 to 6 months, we have started with the ciprofloxacin, and there has been no recurrence as such about infections as well. So we are trying to find out if topically also we can continue the same. So we are ongoing with the study at this point of time.
Because both are fluoroquinolones.
Yes, sir.
So it would be better if you continue same
ciprofloxacin,
drug,
yes,
rather
sir.
than changing the drug.
Yes, sir. Thank you, sir.
We come to the end of the session. Thank you very much for all the speakers. They've spoken very well. The free paper session went off very well. It's unfortunate that 5 speakers presenters did not turn up, which is unfortunate. So I think, yeah, because the trouble is that we could,
there was better discussion also.
We couldn't have started.
अच्छा पहले इनको कर देते हैं क्या अभी पहले तो लिस्ट आ जाए लिस्ट
सर को सारे शीट भी तो आएगी वो आ जाएगी शीट बुलाओ तो सही टाइम बचाओ अगर सारे लोग आ गए तो